we hope to see many more and more attendees in this and the future meetings. I would like to take opportunity first to thank the annual committee program members and chairmen, and that's Mark Haki and Michael Dake, to really who spent incredible amount of time to put this very exciting program over the next 3 days, 3.5 days, as you see, for such a small society as we are, to almost have 55 faculty and 13 sessions is really a very, a big step. I think that the program has been carefully chosen to represent all different aspects of the neurovascular diseases, with emphasis of the venous diseases, from the basic science to the diagnostic techniques, to the imaging, to the ultrasound, to flow studies, physics, iron, and finally clinical and treatment aspects. I hope that you will enjoy the program and help us learn more, and we promise to do our best during these 3.5 days. Obviously, we can grow only if we can get more members, and I encourage you very much that if you will enjoy this meeting, to stimulate your colleagues to become members of the International Society for Neurovascular Disease. This evening we will have a reception, opening reception, and I welcome you to attend this reception later this afternoon. We are already very excited because there have been 4 workshops running yesterday and today, and I think that we accomplished a lot in understanding how we are going to move forward on several topics. Now, obviously, we are already late, 15 minutes, and I would like that we give really more time to the keynote speaker and to our gold medal award. And so I'm going to stop here and introduce Mark Haki, who is going to introduce our keynote speaker. Mark.
Thank you very much, Robert, and welcome everyone. The interesting aspect of the International Society for Neurovascular Disease was it really started out with a thrust by work by Paolo Zamboni and a focus on multiple sclerosis, and going back and reviewing old concepts on the role of venous abnormalities in multiple sclerosis. But it quickly became clear that these venous abnormalities, which have pretty much been ignored for 100 years while we've focused on the arterial side, are really very important. Perhaps the easiest way to say it is, if you can't get the blood out, you can't get it in either. And we found that now there is evidence for abnormalities in things like exertional headache, transient global amnesia, multiple sclerosis, Parkinson's disease, and maybe other diseases for all we know. So being from Detroit and having had many opportunities to interact with Michael, and whenever I really had a difficult question related to anything neurological and flow related or cellular biology related, the only person I could really turn to was Michael. And he has really been a tremendous source of information, and he has really the perfect experience, I think, to talk to us today, because his interests are looking at angiographic effects as well, looking at potential treatment. He has experience in animal studies and human studies, and his interest is in microvascular pathophysiology. So Michael, I couldn't think of someone better to give this presentation, and we're really looking forward to it.
you. I'm absolutely delighted and honored to speak to you and present some of our data to you today. And in addition to that, as Mark well knows, it's wonderful to get out of Detroit in February, particularly to Florida. So, we have a choice in life, multiple choices in life, particularly when it comes to diseases. We could focus on the injury, and the society here talks about, in its title, is disease. And we could treat neurological disease by the treatment of the lesion. Let's say if someone has a stroke or MS or a traumatic brain injury, we could try to reduce the lesions, and therefore hopefully the patient will improve neurologically. However, that really hasn't shown much promise in so many diseases. There's another approach we can take. And I believe it may be the more fruitful approach. That is, instead of treatment of the lesion, instead of the treatment to reduce damage, again, we'll get into the vascular components, and that will be the center of my talk. Essentially say, forget about the lesion. What we should be doing in neurological diseases is treating the intact tissue, stimulating endogenous restorative mechanisms within the brain or within the central nervous system. And at the end of my talk, I'll talk to you about the peripheral nervous system. So, I'd like to spend the next 4 hours, but I think that's what Mark was, I think, telling me. Keep to time, he did. But I want to describe to you an incredibly important role of the vasculature in the treatment of the intact brain, of turning on, stimulating endogenous restorative mechanisms within the injured nervous system. And what I will describe to you, and I'm going to give you somewhat of a survey. I'm going to describe to you how there's an exquisite orchestration. It's almost like a symphony of recovery that occurs when you stimulate these restorative mechanisms. There's a primary role of the vasculature, a stimulation of angiogenic, vasculogenic processes that subsequently stimulate neurogenic processes in the brain that also interact to promote neurite remodeling. And I'll show you how these weave together to create maybe a tapestry, whatever metaphors you want to use. But I'll describe to you how one turns on the brain and stimulates vascular processes that produce many factors that end up in improving neurological function. Again, with the focus on the treatment of the intact tissue and not the diseased tissue. So maybe we'll alter the name of the society down the road. Now, we're going to approach this two different ways. We're going to approach this, I'm going to describe to you briefly, whoops, I didn't mean to do that. Go back. Good. We'll talk about cellular treatments. And I like doing cell therapies because I really like this slide also. And I'll describe to you how administering cell-based therapies exogenously through a vascular route stimulates recovery, primarily stimulates vascular responses that then down the road turn on recovery. And I'll essentially tell you that when you use a cell-based therapy for the treatment of disease, neurologic disease, what you are doing is you're not replacing tissue, as has been promulgated and it's been the dogma for many years and has caused me great aggravation. What you're really doing is the cells that enter the nervous system interact with parenchymal tissue, turn on astrocytes, vascular cells, and endothelial cells to produce many factors. So I'll describe to you as a model of recovery how cell-based therapies stimulate the process of recovery. Then I'll talk about some pharmacologic therapies that turn on these processes. And I'm going to limit myself to treatments that are presently in clinical trials. So cell-based therapies, there's a lot of work being done throughout the world in cell-based therapies, and I'll demonstrate to you the important role of vasculature, and also a number of pharmacologic therapies will also show you the role, essential role of stimulating angiogenic and vasculogenic processes to turn on recovery. Okay, let's talk about stroke. One of the reasons I study stroke is that it's a very nice model. It's a relatively simple model. I could create an infarction. A lot of people get strokes also. I could create an infarction, dead, damaged, compromised tissue, and then if I could then see if I could stimulate the intact brain to compensate for the damage. So stroke essentially is a model for traumatic brain injury. It's a model, maybe a model for MS and other aspects of neurodegenerative disease. But it's relatively simple. I could do this in young animals and old animals. And we use pretty decent models that are clinically relevant. We essentially turn on, we place a clot at the origin of the middle cerebral artery, and we could block flow. This is angiography. Here's my clot. And you could do all your MR measurements and show you really get a very nice reproducible lesion that is clinically relevant and really simulates what occurs in the majority of human ischemic strokes, middle cerebral artery occlusion. Okay. Let's talk about treatments now. And then we'll get into the mechanisms and the role of the vasculature, particularly the microvasculature, in stimulating recovery. So you give this animal a stroke. This is a middle-aged animal, a baby boomer animal. And animals after stroke, as humans, have very sudden onset of neurological deficits. And pathetically, what we presently have for the treatment, if God forbid one of you get a stroke, what we have to do is call 911 very quickly, get you to the hospital within the first 4.5 hours now, give you tissue plasminogen activator to lyse the clot, and maybe some of you will show some improvement in neurologic function. In the United States, fewer than 5% of patients get TPA, and even those who get still end up in trouble. So 97% of your patients really have major neurological dysfunction. What do? Well, we do restorative treatment. We don't treat the lesion, we treat the intact brain. So in this particular example, I take a cell-based therapy, I administer those cells intravenously. The cells travel to the brain. And we do, as we do in patients, we have to treat animals. It's actually much easier to work with the animals. We could give them far more extensive neurologic outcome tests than we do patients. We could spend more time on them. They don't complain much. So we do a whole battery of tests, and I'll just show you one example of a test, which is a somatosensory test. And if you're a rat, and you have a little red tab on your paw, particularly if you're a Detroit rat, you rip it off very, very quickly. And you measure if you're intact, neurologically intact, couple of seconds are off. If you have a stroke, it's going to take you a long time to rip off those tabs. So you have an index of how that animal is functioning. So what we do is a week later, give a treatment. Not 4.5 hours, not 3 hours, not 4.5 hours. We administer a cell-based therapy intravenously. And what I'm going to measure the time it takes to rip off the tab. Prior to stroke, my animals rip them off very quickly. After stroke, it takes forever. I stop it at 2 minutes. If I treat the animals 7 days after stroke, I get very substantial and persistent neurological improvement. Okay. Where does the vessels come in? What is the underlying basis of this? What's evoking these processes? Well, a lot of angiogenic factors stimulate recovery. And I'm going to show you that they stimulate angiogenic processes, and I'll also demonstrate to you by the end of this talk, if I'm not thrown off stage, that they also stimulate neurite outgrowth and have profound effects on function. One of the interesting trophic factors that I am passionate about is that I consider maybe my first violin in my orchestra of recovery is vascular endothelial growth factor. And I'll demonstrate to you that VEGF turns on a lot of good stuff. One example. Let's take an animal, give the animal a stroke. Or give an animal an injury. Give the animal cells. And in this case, the experiment would be, I'm going to give the animals human cells. Okay? So I have an animal, a rodent. I give the animal human cells, and I'm going to measure VEGF. And I can measure, VEGF comes in multiple flavors, 2 flavors, a human VEGF and an animal VEGF. If I give the animal human cells and I look for VEGF in the animal's brain, what I find is a significant upregulation of animal VEGF, of rodent VEGF. What is that telling? What is that telling you? That tells you that it's giving the cells, is giving the human cells, your cells, let's say from your bone marrow, those cells are then stimulating within your brain, are stimulating your own VEGF. And I could demonstrate to you, and immunohistochemically, that a lot of the VEGF is produced both in the astrocytes and the vasculature, and VEGF is good. VEGF is good. So I'm stimulating recovery. What does VEGF do? And this is where some of the vessels come in, and we'll delve into this a little more deeply. VEGF turns on angiogenic processes. And if I look at the boundary of the infarction, I will see a significant increase in vascular density. And I could do BRDU measurements. I could demonstrate to you that there's a significant increase in angiogenic processes. So, you're being scientists. You say, who cares? Because you have an infarction, you have dead tissue. It's not Lazarus. You're not going to bring this dead tissue back to life. But what the new vasculature does, and I'll demonstrate to you here with the brief in vitro experiment, what the new microvasculature does is turn on, produce subsequently other trophic and angiogenic factors. So it's not simply that you're increasing perfusion, which is good. I'm not against perfusion. But what you're doing is stimulating microvasculature in the brain becomes ontogenic vasculature. It's almost a recapitulation of ontogeny. These new vessels produce many factors that are very potent to stimulate recovery. So you could do some in vitro experiments, and I won't go through these in details because of time issues. And I can show you that if I take endothelial cells and I expose them to exogenous stem or progenitor-like cells, what I find is I have an upregulation, actually, of many pro-angiogenic and other trophic factors. So the endothelial cells themselves, the microvasculature in the injured brain, which is treated with a cell-based therapy, becomes factories for the production of other factors. And what does this do? What do the blood vessels do in the brain? Well, by producing these other factors, they then turn on neurogenic factors. You very likely know that even into very old age, you constantly produce new brain cells, primarily neuroblasts. And there's certain sites in the brain where the production primarily occurs. There's the dentate gyrus and the hippocampus, and the subventricular zone. And the subventricular, I'm going to focus on the subventricular zone because when you have an injury to the brain, there's a tremendous proliferation, upregulation of neuroblasts, new types of brain cells in the subventricular zone. And this just illustrates it. And when you treat with a restorative therapy, whether it's cell-based or pharmacologic therapy, there's a significant increase in the numbers of these cells. And what these cells do, having new brain cells is very good for you. If you run, you exercise, and I'll get to that a little later, you're going to produce new brain cells, and you're going to be smarter. The data is overwhelming that the production of new neuroblasts throughout the central nervous system is very important for your intactness. Okay, what do these cells do? In the normal brain, usually in the normal brain, whether you're a rodent or a human, what happens is that that these newly produced cells travel down the rostral migratory stream to the olfactory bulb. They go and they travel like down I-75. I don't know if I-75 goes down to Orlando. But they go along a major highway down to the olfactory bulb. However, when you have an injury to the brain, and this is where the microvasculature is going to come in. If you have an injury to the brain, whether it's a stroke or it's a trauma, what's going to happen is that these neuroblasts will travel off-road. They're going to go off I-75. They're going to go off the RMS and move and migrate to the lesion site, miraculously. But it's not so miraculous. There's science behind it. We definitely understand why that happens. And my work didn't work. And here you actually see neuroblasts. See these green things? Over here, they are neuroblasts, and the neuroblasts are traveling to the microvasculature. The microvasculature in the boundary of the lesion is attracting these neuroblasts. And the question is why? What is happening? What is the role of the vasculature in, why do they attract these neuroblasts? What do they do to the neuroblasts? Let me give you a touch of background information. Neuroblasts are like teenagers. They are not fully formed. They could become anything. And so depending the environment they're in or who they're hanging out with, they could become astrocytes, oligodendrocytes, neurons, and they really could become good stuff, bad stuff, whatever you want. But you have to turn them on. You have to create conditions where they become neurons. And so they'll migrate to the microvasculature, and here you actually see an immuno where I have my neuroblasts embracing or dancing. I like using the metaphor that they tango with the vessels. And the question is, why do they tango? What's going on in this dance, in this embrace? What is the vasculature doing to promote this neurological improvement? To really understand, you could go in vitro again. And for the sake of time, I'll just give you the end result. And if you want to look at the data, you're welcome to. What happens is that the neuroblasts go to the microvasculature. And what the microvasculature does in its tango is that it tells the neuroblast, you guys better become neurons. And it actually causes the neuroblast to differentiate into neurons. And whoops, I pressed the wrong thing. I always press the wrong thing. It's my kids tell me. And you see there's a significant increase in their neuronal identity. I can block that neuronal identity, that transforming, differentiating the neuroblasts into neurons. I can block that by blocking the VEGF receptor. So you also see my first violin still playing a very major role in the production of the neuroblasts and also in making the neuroblasts differentiate into neurons. Okay. So the blood vessels make neuroblasts become neurons. Good stuff. Now it takes two to tango. And nature has a certain symmetry to it. So if the blood vessels do something to the neuroblasts should do something to the blood vessels. And what you can show, and what I show here in these in vitro data, that the neuroblasts are themselves angiogenic. That if you could do this in vivo, and this is an in vitro experiment, I can take a dish full of endothelial cells, spritz in some either neuroblasts or media from a supernatant from the neuroblasts, and you will form vascular structure. I can block this, or I can inhibit it also with the VEGF, blocking the VEGF receptor. So you see this lovely role of interaction between vasculature, between microvasculature and neurogenesis, and their coupling to produce great music. Okay. So I've given you a sense of, no one smile. I've given you a sense of turning on restorative processes in the brain. And I've told you that vasculature and parenchymal cells produce factors that enhance neurogenesis. If Mark invites me back next year, I'll tell you about the role of oligodendrogenesis and white matter and all that other stuff. But there are other ways to stimulate recovery. There are other ways to stimulate other things also. But so nitric. So let's move into some pharmacological approaches. Years ago, we did some experiments where we gave animals nitric oxide donors. Animals had stroke and trauma. We just gave the things like datanoate and a whole bunch of other agents that stimulate, activate nitric oxide. And the animals did very well neurologically. And again, what we do is we treat these animals a week, a day, a month later, and the animals really do better. So you have to understand what's going on there, particularly if you want to get funded, NIH funded, you've got to get to mechanisms. And what we realized is that what the NO is doing, what the nitric oxide is doing, is turning on, increasing a very important molecule called cyclic GMP, cyclic guanosine monophosphate. And that's a very important signaling molecule. So then we thought, how else can we turn on, increase this very important signaling molecule to activate microvasculature in the brain? Another way to turn it on, to increase the levels, is to inhibit or block its hydrolysis, block its breakdown. So then you have to begin looking at what are the factors, what are the enzymes that break down cGMP. And it turns out there's a very important enzyme called phosphodiesterase 5. And therefore, what you want to have is a phosphodiesterase 5 inhibitor, which is the world's most popular drug called Viagra, Cialis, and all that. And it's now in clinical trials. Pfizer has a 700-patient phase 2b clinical trial working, giving stroke patients. And I have very happy rats. And I made so many friends. It's amazing the numbers of friends I made when I started these studies. So what we then did, and I'm going to show you, I just don't want to give you a sexy talk. I want to illustrate to you the essential role of the microvasculature in turning on recovery of function. So I'm particularly into stroke as a disease of the aged, and what you have to then do is have animals that are old and see what happens. If you want to have a decent treatment for stroke, you really should use models that are clinically relevant. Take an old animal and treat the animal, give the animal a stroke, and see what happens when you treat the animal. So we did these experiments, and we gave the animal a stroke. We did all these neurologic tests on these animals. And this is another example of a neurologic test. We don't have to go into the detail, normally, but I'll describe because I can't control myself. Animals, if you're an animal and you walk to a corner, you have a 50% probability of turning left at the corner, 50% probability of turning right eventually. If you have a stroke or an injury to the brain, you'll turn in one direction. So you can measure the number of times the animals go back and forth in the different directions. And so what we did in these studies was we gave these aged animals a stroke. We then treated the animals a week later. I like a week because it allows me to go to some island or to Florida in the winter. And you see a very profound improvement in neurological function, even in the aged animals. Does vasculature play a role here? Does VEGF play a role? Does angiopoietin-1 play a role? I'll demonstrate that to you now with the Viagra and with some other agents, and essentially sure does play a role. And I could show you that Viagra, sildenafil as its formal name, significantly increases VEGF in the brain. It also significantly increases vascular density, angiogenic processes. These are the young animals, these are the old animals. What's interesting, a lot of this may be interesting to you, but what I find really nice is that even in the aged animal, you can still stimulate these restorative processes. You can enhance angiogenic and neurogenic processes. So with an agent like sildenafil, some other agents, the percentage increase in neurogenesis is the same as it is in the young animal. So it gives aging people some optimism, some promise. So it turns on angiogenesis, and again, I'm just going to give you a little survey of studies that have been translated to the clinic. So what we found with sildenafil and equivalent agents in PDE5, that vasculature plays a very prominent role. The production of trophic factors from the vasculature, the enhanced angiogenic and vasculogenic processes play a prime contribution to the treatment of neurologic disease. Okay, better hurry up. A couple of other agents that I really like. People go running and do stuff like that, and to exercise to increase their angelic HDL, high-density lipoprotein, but to overcome the evil LDL. And you could do that actually very cheaply. I like going to the gym and all that stuff, and running. I'm a runner, but if you're too lazy, what you could do is take niacin, or essentially low-dose niacin. And that vitamin B3 has a significant increase, enhances HDL. And you could show that if you have an animal, give an animal a stroke, middle cerebral artery occlusion, significantly improve neurological function. What are we going to look at now? We're going to look at what's happening in the microvasculature. And again, I'll demonstrate to you that a key element in these whole restorative processes is the stimulation of perfusion in vasculogenesis, angiogenesis, and you could beautifully show that there's a significant improvement in perfusion by means of MRI. And I can look at arteriogenesis, I can look at arterial structure, and clearly show that there's a very nice, significant correlation between arterial diameter and a whole array of different neurologic tests in these animals. I just included this slide because there are a lot of people with diabetes. And I just want to make a slight editorial. Diabetes is, I think, to a large extent, a vascular disease, has profound effects on the vasculature in the brain, and I'll show you in a few minutes, in the peripheral nervous system. And just making the point that if you treat with some of these restorative agents, if I take an animal that's diabetic and administer things like niacin and some agents, I could significantly reduce blood-brain barrier breakdown and leakiness, and really enhance the intactness of the vasculature. Let me just finish this part of the talk, and I'll want to get to something else, just with one other agent that I really think is very important, not because I eat cheeseburgers. I prefer good ice cream. But because statins have a very important role and are in clinical studies now for multiple neurologic injuries by us, what we do is we use statins to treat, we have a clinical trial to treat intracerebral hemorrhage. So this is just some preclinical data using a this isn't a collagase model. We inject blood into the brain. These particular studies that were done by Don Seyfried et al. Show you that if you inject blood into the brain, you generate essentially a model of intracerebral hemorrhage. You could significantly improve neurological function by treating the animals with statins. And we've now treated 21 patients with this. So statins, I think, play an important role in stroke, in trauma, and they really should be in trials for trauma. Okay. It's not only VEGF. I showed you my first violin before, and I demonstrate to you with cell-based therapies and with sildenafil that VEGF plays a very important role. There are other pro-angiogenic factors that help stimulate recovery. And again, I'm treating the intact tissue and forgetting about the lesion. All these lesions, let me make the point very clear, all the lesions remain the same. So when I have an animal with a stroke or a trauma, I'm not changing the volume of infarction in any way. I'm changing the characteristic of the vasculature in the intact brain, in the peripheral, in the tissue that's peripheral to the lesion. So if I then treat, let's say, an animal with stroke with a statin, like simvastatin, what you'll see is also a significant upregulation of very important trophic factors in the vasculature and also in the astrocytes. This demonstrates that there's a significant increase in angiopoietin 1 type 2. Well, there's an increase in both. In angiopoietin 1 type 2, there's actually a decrease in angiopoietin 2. Ang1 type 2 is, I think, an understudied area in terms of its role in restorative neurology. And what's really cool about the angiopoietins is angiopoietin not only is an angiogenic agent, not only does it evoke maturation of microvasculature in the brain, but it also turns on neurons. In vivo and in vitro, this is data easily observed from primary cultured neurons. Put them in my dish, spritz in a little angiopoietin, and I'm getting a very robust increase in neurite outgrowth. So there are vascular elements, vascular agents that have multiple roles. Let me finish the presentation just briefly. I think I'm almost getting there. Talking about another disease where the vasculature plays a primary role. We've spent quite a while looking at diseases and injury of the central nervous system. But there are a lot of patients out there who have diseases of the peripheral nervous system. And there are a lot of diabetes out there, a lot of patients getting chemotherapy that have peripheral neuropathy. So the question arose is whether we can use some of our restorative agents for the central nervous system in the peripheral nervous system. So we tested some of these approaches, and I just want to take the opportunity to describe one agent that I really like that is a strongly angiogenic agent, and we are moving this into clinical trials of multiple sclerosis now, both because of its vascular processes and also because it greatly enhances oligodendrogenesis and the restoration of white matter, remyelination, and another lecture would be how remyelination couples with vascular changes. That's another issue. But let me talk about restorative processes using this agent, thymosin beta-4, that's actually produced in your thymus. And it can, I think, be a promising restorative agent that has a primary vascular role. So, if you have peripheral neuropathy, you have pain, you also have neurologic dysfunction. That's measured many different ways in humans and the animals. If you were a rodent, you could take your tail, put it into hot water. If you're a normal rodent, that animal will flick its tail up out very quickly. However, if you're an animal with peripheral neuropathy, it'll take a long time for that tail to come out of the water, out of the warm water. And there are other thermal sensitivity type of measurements. You could make a hot plate and also measure how quickly the animal moves its paw up. And what these data simply show, these are normal animals, but tail flick and hot plate test, and you see the animals pick their tails up very quickly. You touch something hot, you'll move it away very quickly. If you're an animal with peripheral neuropathy, you really don't. It takes you a while. You're losing the senses. If you treat with agents like TB4, thymosin beta-4, you get a significant improvement in neurologic function. Why am I up here? Because I have to talk to you about the exquisite role of the vasculature in promoting this restorative agent. And what we then do is look at the microvasculature in the sciatic nerve and other regions and clearly demonstrate a primary role of vasculature. So here we're looking at vascular perimeter as we did in a couple of slides before, and I can show you in an animal that has type 2 diabetes, the arterioles are significantly reduced in diameter. If I take those animals and treat them with agents like thymosin beta-4, I alter the vasculature to bring them somewhat to a normal state. We then also have to look at the vascular function. I can measure the percentage of perfused vessels with Fitzy-Dextran. And again, we don't have to look at the details. The pictures are pretty good, but I can show you that the number of perfused vessels in the sciatic nerve is significantly decreased when you have diabetes, and I can bring those back essentially to normal. I can measure blood flow, and again, the same type of thing, not to kill a dead horse. This gets interesting because it tells us something novel that's consistent with what we saw with the increasing HDL. Ang1. There's also a story with VEGF, but angiopotens play a very important role in the restorative events that occur when you treat peripheral neuropathy with TB4. And what we show here is that if I treat with TB4, I increase angiopoietin 1 expression in the vasculature, and in addition to that, in the Schwann cells. Schwann cells in the peripheral nervous system are equivalent to what? Oligodendrocytes in the central nervous system. I then do some, I'm blinking here, this light, it makes me nervous. I'll do some Western blots, and I will show you that if I treat with thymosin beta, if I treat with the thymosin beta 4, I will increase angiopoietin 1. I will downregulate angiopoietin 2, which competes with angiopoietin 1. And I will then show you that if I treat with an agent like TB4, I significantly increase Ang1 and decrease Ang2. Okay, let me. Again, there's somewhat of an overlap, a multi-function. There's music playing together here. You have a vascular agent that's stimulated by a restorative treatment, and that vascular agent not only enhances the vasculature, causes the maturation of the vasculature, and reduces the leakiness of the vasculature and induces angiogenic processes, but it also promotes neurite outgrowth. So if I take primary culture neurons and give them a little Ang1, I will show you a significant increase in neurite outgrowth. Okay. What have I told you in the last 41 minutes or so? 39 minutes. Disease, treatment of disease that's why we're here. And we should focus on what is evoking, what's causing disease, whether it's MS, what the role of the microvasculature in stroke, and the role in mediating secondary damage, free radical damage after TBI. But there's another way of looking at vessels. The other way of looking at vessels is looking at vessels as potential factories for restorative agents. You could you could stimulate remodeling of the microvasculature in the intact brain and greatly enhance neurologic outcome. And you could do this for multiple diseases. In our models, in our clinical trials, things work. The body is, we were created with the biology that really, when you have an injury, the body reacts very similarly for different types of injury. After you have an injury to tissue, the nervous system particularly desperately wants to remodel itself. Our goal is to assist that, to stimulate those processes. And it really is the use of agents that enhance vascular events, that enhance vascular processes, angiogenesis, vasculogenesis, and the production of its subsequent trophic factors that induce neurite outgrowth that can greatly improve and will give us optimism in that we can actually treat patients with neurologic disease. I just want to acknowledge the people I work for who really do the work. And Lee has done a lot of the work with the cell-based therapy. Jay Lee has done work with with the statins, and Rulan has done work with sildenafil. Zhengang has really done work with everything. The only person I forgot to put in is Lei Wang, who did the work with peripheral neuropathy. But I just want to thank you very much for inviting me here and giving me the opportunity to describe some of the work that we do to you. Thank you. I'll take questions or insults, whatever you know.
Thank you very much, Michael. So enthusiastic. Well, thank you, Michael. I'd actually like to give you a brief challenge, and please come up to the microphones if you have questions. This is a wonderful concept to be treating partly the damaged tissue by using the non-damaged tissue to help regenerate itself or recover. But I have an intermediate question, which is what we're all interested in here right now, and of course marries very well with what you're looking at. There are examples where you can have neuropathy, and using animal models, people have demonstrated if you restrict blood flow to the nerves or you restrict blood flow to given areas, you can get almost immediate immunological response. You can get almost immediate breakdown of the endothelium. You can have vesicles change. And this has been done mostly in the peripheral areas. And if you return that blood flow, the immunological response goes away. The nerves start functioning properly again. Right. If you can catch this at the point where the damage hasn't really occurred yet, where this lack of blood flow is so temporary, or at least not so reduced that you get infarction, but you still have hypoxia and ischemia, and if you can catch that early enough, then it would seem to me that almost everything you're talking about here makes sense, even at that intermediate level. But the question is, can we first investigate if we are at that intermediate level? So maybe these treatments you're talking about would be just as good even when that damage has not taken place yet, to recover the flow.
Yeah, I think clearly there are multiple issues going on, particularly with diseases like peripheral neuropathy. It is not purely an issue of reduction of flow. When what you're doing in the blood vessels within a lesion or really outside the lesion is you're altering the characteristic of the endothelial cells. So someone who has diabetes simply doesn't have a reduction, necessarily only a reduction of flow. They really have different types of endothelial cells. If you do a gene array on the endothelial cells in the blood, they will respond. They will express different genes. So I think flow is something that we all want to improve and enhance. But what the restorative agents really do is alter in a very fundamental way the actual vascular structure by these potent factors, trophic factors. What we're essentially doing is remodeling the compromised vasculature. So it's not only decreased perfusion. I think perfusion, as I've demonstrated to you, is extremely important. But the building blocks, the actual architecture, vascular architecture has been altered, and those have to be remodeled. And some of these agents play a pivotal role in stimulating that remodeling.
Thank you. Yes. There's somebody back there, Bill, just before you. Please go
I
ahead.
can't see anything, so yeah, with the lights.
Go ahead.
It's a great talk, Dr. Chop. I was really struck by...
Sorry, can you introduce yourself?
I'm
also?
Steve Alexander. I was interested in the ratios between the Ang1 and Ang2 that you see as an important, that ratio is an important regulator of nerve recovery and vascular recovery. And, in addition to VEGF-164, there are several other isoforms, and some of them are inhibitory. Have you thought, or are you getting into how differential regulation of those isoforms might be contributing to recovery in these models?
No, that's a superb question, and if I had another lifetime, I would consider doing that. And we did that a number of years ago to look at different isoforms of VEGF, but it's something that really should be worked with. I guess to capitalize or to exploit your question, I'd like to make the point that when you stimulate recovery, what you're doing is activating many parallel processes. It's not only, you have really a symphony. You have many violins. You may have some first and second violins, but there are multiple events that are occurring, and again, another talk, I think these are highly stimulated by microRNAs, which is another way of conceptualizing what happens when you have injury and when you have recovery. But I agree, one can and should look at the various VEGFs.
Thank you, Bill.
May even get a grant.
Bill Code from Vancouver, Canada. Thank you for a very eloquent talk.
Thank you.
Well done and very understandable. I wanted to ask about two very different agents. One's adenosine, whether you've had experience and comment on it. And the other would be acetazolamide, which is a carbonic anhydrase inhibitor, diamox is the trade name for it.
Yeah. Well, years ago, we looked at adenosine when I had black hair and hair. We looked at adenosine. Those agents are, in our experience, at least the publications I know in stroke, are primarily neuroprotective agents. And the focus of this presentation, they play a role in perfusion and neuroprotection. But what I wanted to emphasize here, and the questions really allowed me to do that, is that don't worry about the neuroprotection. It's good. Stabilize your patient. Make the lesion smaller. Give them adenosine. But focus on the remaining tissue, that you can enhance processes that are ongoing, but you can amplify those processes. So whether delayed administration of acetazolamide or adenosine promotes those, I don't know. Those studies, to my knowledge, have not been done. But as acute neuroprotective agents, which I like because it's fed my children for years, no, they've had shown some value.
Thank you. And the final question, then?
Bart Locanthe from Google. You mentioned how time is so important in human stroke.
Yeah.
But then you talk about 7 days with rats.
Mm-hmm.
And I'm wondering, have you started having different size vacations to see?
Yeah, particularly in the winter. I mean, I really have. I do 1 month treatments in February in rats in Detroit. We've gone out with and published treatment, these restorative treatments out to a month after stroke. And the clinical trials, for instance, with the study that we did with sildenafil in stroke, our treatment was from 3 to 7 days. I'm not sure what the Pfizer study is. Cell-based therapies, which are now moving, and there are some clinical trials are going out. There's some people doing it up to 6 months post-stroke, and we've gone out to a month post-stroke. So I think what we've shown by MR, and I'm glad Marcus here, we've shown you could take a brain, whether it's a human brain or an animal brain, after an injury, whether it's a TBI or stroke, and you're going to see dynamic changes at least over a year. You're going to see inflammatory responses. You're going to see changes in ventricular size, structural changes in the white matter. That brain, after an injury, is receptive to stimulation and promoting recovery for a very long time.
Michael, thank you again for an
Thank you.
exciting talk. So Michael Dake is going to come up and continue this session.
Thank you, Mark. I'm Mike Dake from Stanford University, and first order of business as co-program committee chair along with Mark Hakey is to express our appreciation to all of you for being here, for taking time out of your busy lives and coming down to join us in Orlando and share our interests. Secondly, in addition to your contributions, I want to publicly express gratitude of the Society to our sponsors, those organizations, corporations, educational institutions, and individuals who've chosen to financially give us the support that would enable this Society's meeting. Now it's my I should mention also that those corporate sponsors are acknowledged in your program, and you've seen them, I'm sure, on the slides on either side of me during the breaks and during the discussion periods. And during breaks and before meetings, many of them are next door in the adjacent room. So please visit them, talk with them, share your interest, find out what they're doing. They may have questions for you. I think that's all part of this Young Society's opportunities. Now it's my distinct honor and pleasure to introduce to you someone who really to this group needs no introduction. The inaugural and now immediate past president of the Society, Paolo Zamboni. Paolo is director of the Center of Vascular Diseases at Ferrara University and is obviously a pioneer and the first to describe CCSVI and detail its association with MS. Paolo is going to introduce and present the Society's first gold medal award. Paolo.
This year, the Society decided to award with a gold medal Dr. Franz Schelling. Dr. Franz Schelling is awarded for his career. He was really a pioneer in studies relating venous circulation to multiple sclerosis. He continued the tradition of a research trace coming from Charcot, Putnam, Fogg, and other very important researchers in the past. He performed a study in the 70s and in the 80s, and also, very important, stimulated a lot of researchers all over the world to investigate the venous circulation in relation to neurodegeneration. So for this reason, I call him on the podium, of course, Franz, to award him
Thank you very much. Do you recognize this image?
It's a wonderful present. Thank you very much. It's the greatest present I could imagine. Thank you.
Now I want to introduce Franz with his lecture, his CCSVI in MS, weighing the findings. Thank you, Franz.
Thank you, Paolo. It's actually only thanks to you and a colleague of yours that I had again the courage to begin in 2002 to investigate and to follow up the issue I had actually given up after Congress. Thank you. This one? Yeah. The title which I chose for this presentation is Weighing the Findings of CCSVI in Evaluating MS. It was only Paolo Zamboni who found an opportunity to check the extracranial venous drainage in MS patients. I had severally tried to do this at post-mortem. In our local pathology, I had the opportunity to control studies, to study the venous patterns by injection and the venous valves by fluid measurements. And I tried to do the same in MS patients. It cost me my post in neurology. I went to radiology and tried to carry on, and I was in the end limited to literature studies, and so I had to confine my study at first to postmortem evaluations from the literature. And I was amazed that nobody had thought that veins must play the most important role in MS, because all the postmortem findings were clear evidence for me that there had to be a lashing back of blood into the brain, along the straight sinus, and into the epidural spinal veins in spinal MS. And I actually was never, as a student, I hated the subject of MS because I thought it was a mere artifact. And I was more interested in the problem of venous stasis because I worked on hydrocephalic children in 1970, 1971. And it was for me a problem, how did this intracranial pressure build up despite all the venous outlets which could compensate this excess pressure. And I imagined there must be some hindrance for venous outflow from the skull. And this is important in the context of CCSVI, because as I see, CCSVI is mainly studied as a stasis problem. And for me, it's a dynamic problem, a problem of abrupt, intermittent venous flow inversions, hitting back into the brain and spinal canal. And so I thought it would be important to show the difference between stasis, the effect of stasis and the effect of reflux. Here you see the main features of stasis. You have at first plethora and then edema if the oncontic pressure is exceeded by the transmural pressure along the venules. It's in the whole body. In every organ it's the same, from the leg up to the brain. And then if you have more severe obstruction, then you get hemorrhagic infarction, you get edema dotted with hemorrhage, and the tissue dies. The problem for me was, as I said, at first hydrocephalus. And I wanted to know whether the emissary veins, the venous outlets of the skull, played a part in this development of hydrocephalus in children, also in adults. And then I studied the literature, and I found there was a lot of evidence from otitic hydrocephalus in 1850. It was observed if you had inflammation of the ear and it obstructed the lateral sinus, then you could get hydrocephalus. And now, in the last decade, it has been possible to study transstenotic pressure gradients in hydrocephalic patients. And it was required to have pressure gradients of 10 to 50 millimeters of mercury to have the tendency to develop hydrocephalus. And interventionalists only ballooned lateral sinuses or put in stents if the pressure gradient along the lateral sinus, the stenosis was more than 10 millimeters of mercury. I wondered about this span. Why is it that you have some patients which only develop hydrocephalus with 50 millimeters of mercury? And then I had in 1973 to 1978 the opportunity to study more than 1,000 skulls at the Anatomical Institute of the University of Innsbruck. Maybe just this point. In CCSVI, the curious thing is that you have transstenotic pressure gradients of far less than 10 millimeters of mercury as a rule. And despite this small difference, you have dramatic clinical effects if you dilate such stenosis. So there must be an intervening factor. And for me, one intervening factor was the cranial venous drainage. I had measured out all the venous outlets of the human skulls in 1973, in the following years, which I could get hold of. And this is the result. In 200 well-preserved skulls, I had to limit the study to the skulls where I could study every venous passage. And I calculated the conductivity of all the single venous outlets and added them up and put them in relationship to cranial volume. This is the raw material, simply the conductivity of all the venous outlets in these 200 skulls. And here you see there are few skulls which have very narrow venous outlets. And there is flattening out a larger number with very wide venous outlets. And I wondered whether this could play a part in hydrocephalus also. And to clarify this point, I went to neurosurgery in Salzburg. I did this study at Innsbruck. And in Salzburg, I worked in my spare time in the archives and checked all the cranial radiographs, which I found for very narrow and very large venous outlets. I had only a few skulls with narrow outlets, and there was no record of cerebrospinal fluid pressure, so I didn't find any correlationship. Then I went to the larger openings. I had expected hypotensive syndromes, hypotensive cerebrospinal fluid syndromes. And the curious thing of these 120 skulls, which had very large openings, it were 4% of the 3,000 skulls I had examined, 80% of these patients had a history of multiple sclerosis. I must admit I hated the subject from my studies. I always thought the subject, MS is not defined by organic criteria. There is no substance, no bone, and when I studied the evidence, I found no convincing evidence for autoimmune processes or inflammation as a primary event, not as a secondary event. And so I was obliged to start afresh, and I went to pathology. And the strangest thing I could imagine, the first illustrations of cerebral MS were for me clear evidence that these lesions had been produced by a lashing back of venous blood through the stride sinus into the area around the lateral and the the first ventricle of the brain. The reports, I just tried to summarize what I had found in hundreds of papers. The lesion veins, this was mainly shown by Dawson. They grooved the surface. This was shown by Ingrid Allen from Belfast, and tunneled in the walls of the cerebral ventricles. This was mainly shown by Dawson and his teacher Bruce. And later there were more exacting studies. It was found, especially by Colin Adams, that the lesion veins had deformed walls. This was also shown by Putnam in 1937. And they were grotesquely dilated and deformed and showed severe damage to their veins. There were even ruptures of strong-walled veins, large collecting veins. What was mainly noticed by Fogg is that the lesions, he explicitly stressed this, the lesions did not form usually the axis. In ADAM and EAE, which are usually put together with MS, this is exactly the opposite. And Scheinker especially showed that the lesions can be actually at the margin of a vessel, as in hypertensive, in arterial hypertension, hypertensive encephalopathy. This was 2 times shown by him. And the result was, of all these observations, that the lesions had to spread in the brain at least from the larger to the smaller veins. And there had to be some mechanical force behind this. It was a physical phenomenon which had to be explained in physical terms. In 1981, and this was the year when I did this study of the cranial radiographs in Salzburg, Young in Hammersmith Hospital in London had done the first MR imaging of a patient with MS, and it gave clear evidence of 1,000 fingers. Again, clear evidence of venous damages which advanced from the ventricular border in direction of the cortex. And if I studied all the serial observations in MS patients they were mainly between 1984 to 1990. Then it slowed down the study, and it showed the striking fact which was again corresponding to postmortem studies, that lesion first indent and punch into. This is a pathological term. In MR imaging, it was mainly said that they were cut out of the ventricular border, and then they undulate off the ventricular border. They form waves actually arising from the ventricular border, and all these waves are centered by veins, relatively large veins. And in these serial studies, it was from CT to MR imaging always the same. The ventricle-based lesions were quite stable. They slowly advanced into the brain, but lesions which were farther out, the Steiner splashes of the pathologists and the ovoid lesions of MR imaging, they tended to disappear and reappear, fluctuate in size, and they showed all sorts of enhancement patterns. Robert will be the best man to comment on this. And the enhancements were typically the least frequent and the least manifest if the lesions began to approach the gray matter of the cortex. And it's easy to understand because the cortex is far more pulsatile and has a stronger tissue, and so the lesions tend rather to develop in the white matter. This was when I had given up. After this presentation, I thought it doesn't make any sense anymore to try to convince somebody of this venous concept. I presented this at the meeting of MR imaging in Glasgow. I made a folder similar to the one presented in this abstract book, and I simply drew in this picture of Charcot, this is from 1884, the veins which typically are arranged in this pattern, and the thing which is interesting in regard to MR imaging is that these waves can only be caused by pushing back of venous blood. This is evident from one single slice on MR imaging. There is no other possibility. I would be very glad if anybody could explain it in a different way, especially in immunological terms. In the brainstem, these lesions were already shown in 1831 by Carswell, Charcot showed exactly the same. In the meantime, also Cuvier. These lesions are rounded. And these lesions are vein-dependent. It was only found by Lumsden in 1970. Here, these lesions are entirely different. They are not vein-dependent. They don't show any relationship to veins, but they are typically correlated to these lesions in the brainstem and to these lesions in the periventricular area. And these lesions, it was found after 140 years. After the first illustration by Carswell, are fibrotic lesions. And the name of multiple sclerosis comes from these fibrotic lesions. It was best shown by Froman in 1866 that the insertion, the line of insertion of the denticulate ligament, which forms the point of origin of these lesions. And they can cross the spinal cord. And sometimes you have lesions at the posterior median septum, and then you can even have diagonal lesions. And to explain these lesions, it's only, I had to go back to many other observations in other fields. It was actually shown, the most recent documentation of such a lesion pattern was given by Kahn, and he showed that disc protrusion causes exactly this lesion pattern. But it's more limited. It's just a short segment. And it's done because the protrusion pushes the spinal cord back in relation to its dural sheath. And then you have a tension along the denticulate ligament, and you have exactly the same damage to the spinal cord, but only segmentally. It's only in a very small area, just limited to the disc. And in war trauma, or experimental trauma of concussion of the lower spinal column, you have all along the spinal cord exactly this lesion pattern. And if you look into the abstract book, I took the first illustration of Charcot of MS, and there you see damage which also ends up at the upper end of the denticulate ligament and goes down all along, down to the conus terminalis of the spinal cord. So I had to find an explanation for this, and for me, I had to look for a pump which could produce such a pressure gradient, a movement in the subdural, within the dural sac, which could damage the spinal cord all along its flanks. And then I remembered I had to do myelograms in Innsbruck in 1970, and if the patients were coughing, the contrast agent disappeared. It was pushed up in the direction of the brain, and you had no contrast anymore. And then I looked for the literature, and I found that already in the 1940s, in Reitan, Hakan Reitan had observed this in Oslo, and in Marseille, 20 years, almost 30 years later, Strenta Filstroff had observed exactly the same, that subarachnoid fluid can be displaced just within a fraction of a second if there is coughing or sneezing of the patient. And this can only be explained by excess pressure in the abdomen, which displaces blood from prevertebral veins in the direction of the epidural veins. And if these veins compress the dural sac from below in the conus region, then the whole content must be displaced in the direction of the brain, and you must have exactly this lesion pattern. The conclusion is actually, what I am most interested in is to have the missing link between these pathological observations and CCSVI observations. And I think it's important to focus on venous flow inversions, on the motors of the venous flow inversions. In the abdomen, it's clear, this is the diaphragm and the abdominal wall. In the chest, it's the muscles of the ribs and in between and of the back. And in the neck, it's very complicated. In the neck, we have 4 possibilities, between 1 and 4 possibilities for reflux from the neck veins in direction of the brain. It depends on individual anatomical variations. But I could teach too much. I think I have exceeded my time. I just wanted to thank my son Bernhard, who gave me the opportunity to present my book on MS after 10 years of negotiations with editors of universities, and I tried it with more than 150 editors. I was always told my book is too expensive and because of its colored illustrations or not of interest to experts in the field. And San Matthias gave me, he produced the slides, I just wrote the text. And English teacher John Christensen was assuring me that my explanations could be understood, at least from the language point of view. My wife Elizabeth had much to suffer because of my fanatic following of this area. I'd like to thank you for your attention, and I hope I can advance or at least contribute to further advances in the field of CCSVI and MS research. And I wanted just to point out that, to my opinion, the most important thing is to get a continuous monitoring of venous blood flow along the straight sinus. The ideal thing would be to have it the whole day around. In 1981, I imagined to have a helmet, transcranial Doppler monitoring, and if there were flow inversions during certain movements, because it's various kind of muscular obstructions, we can also alone produce these damages, that the patient would be alerted to this phenomenon, to these dynamics. And in the spinal canal, it's far more difficult. And here I think it's only MR imaging which can solve this riddle. It's these shifts of these subarachnoid fluid shifts and displacements of the spinal cord can only be traced with dynamic MR imaging, and you need a very good temporal resolution and spatial resolution to find out how this mechanism is working in the individual patient. But then you can have a very, very exact elimination of the disposition to venous reflux into the spinal canal or higher up into the brain. If you know exactly, these veins are channeling, directing the flow into the brain, and the other ones are responsible for the spinal damage. Thank you very much for your attention.
So thank you very much, Franz, for your insight and concepts and ideas. And I know that Franz continues to be in touch with many people in this audience and adds his insight into some of the research going on in ultrasound and MR and other areas. And thank you for continuing to be active in this area, Franz. And there's definitely time for a question here if anybody would like to ask one. David?
So it's as simple as measuring the venous pressure in the sagittal sinus after a cough, that would be our answer?
It's not simply a cough. The problem is you must have a certain damming up of blood in the jugular vein, and the blood must be prevented from escaping in direction of the heart. And this is a dynamic phenomenon. You have two muscles which cross the jugular vein. It's the omohyoid muscle and the digastric muscle. And these muscles alone, if they are innerved, if they contract, they can obstruct the jugular vein. And if then you have activation of the sternomastoid muscle, then the blood is displaced in direction of the brain. And the problem is to know why it is only the area of the straight sinus which is affected. I think this channeling is the crucial point. And it was not studied as yet. I wanted to do it at postmortem. I thought to inject one jugular vein with one color, the other one with another color, and to push the contrast medium at the same speed upwards and to look how the distribution pattern of reflux at the confluence was. Because autograde distribution has been studied here in the United States, but the opposite, and especially reflux with a very high speed and a short duration, will be distributed in very changeable ways. It's not simply a matter of anatomy.
Because as you know, we haven't found any abnormality in the flow of the sagittal sinus.
The problem,
any of the sinuses.
That's within the sinuses, you don't have any abnormality in normal cardiac gating, even in many patients with respiratory gating. Paolo actually was the first to show that intense expiration could revert the flow within the cerebral veins in MS patients. But he found this only in very severe cases of MS, as far as I can remember.
Thank you very much again, Franz. We all have our challenges now that you've posed to us. Thank you. And so we're going to stop here and then come back in half an hour. Please come back at 4:15. It's a little delayed, but coffee's next door, and then we will continue here at 4:15. Thank you.